Welcome back to Aging into Anatomy, the Aging Lung, Part 2. Let's talk about the clinical implications of lung aging. The clinical implications are that you get potential analectasis that promotes hypoxia, as well as pneumonia, which is why deep breathing exercises are important. The alveolar mismatch with the blood is exaggerated in the supine position, so we therefore want to try to promote upright positioning and deep breathing exercises. Here's a study published in the British Medical Journal in 2008 that showed that a smoker at 50 years of age has the lungs of a 75-year-old, and by stopping smoking, you can delay this course of lung deterioration. During the study, it was found that by showing middle-aged smokers their age-equivalent lung function, that 40% of them decided to stop smoking, as opposed to the traditional methodology of the physician or provider verbally asking them to stop smoking. We want to keep emphasizing that the supine position exaggerates decreases in PO2 and hypoxemia. With lung aging, there's a steady increase in cancer with age. It is obviously compounded by secondary smoke and primary smoking. In youth, protective factors are in place to thwart the development of a primary lung cancer. However, there are certain molecular subtypes of lung adenocarcinomas that are enriched in younger adults, such as ALK and ROS1 translocations, which challenge the notion that advanced age drives tumorigenesis in these patients. As humans age, there is a precipitous rise in the incidence of lung cancer diagnosis. There are certain molecular subtypes of lung adenocarcinomas that are enriched in elderly patients. The increase in lung-resident senescent cells and the decrease in immunosurveillance may potentiate other cell-intrinsic pro-mitogenic alterations that may ultimately result in lung tumorigenesis. In centenarians, rates of lung cancer incidence and prevalence surprisingly decreases, but why this occurs is not fully understood. There remains a possibility that putative molecular and immunologic alterations with age may provide a biological basis for why elderly patients with COVID-19 have increased mortality. SARS-CoV-2 infects A-T cells, where the angiotensin-converting enzyme 2-ACE2 serves as a receptor for cellular entry. ACE2 is an interferon-stimulated gene in lung tissue. It is unknown how ACE2 levels change with age, and whether altered interferon signaling cascades with age impact the expression dynamics of the SARS-CoV-2 receptor. Multiple pulmonary immune effector cells undergo changes in the aging lung, including neutrophil infiltration and alveolar macrophage activation. An overexuberant pro-inflammatory response triggered by SARS-CoV-2 in the background of inflammaging and an already skewed population of aged lung-resident macrophages may be a lethal combination leading to increased mortality in infected older adults. Reduction in naive TB lymphocytes in aged individuals leads to decreased antigen-specific T-cell responses and reduced antibody titers. The increased frequency of terminally differentiated T cells and cytokine dysregulation from inflammaging leads to a T cell auto-inflammatory loop with macrophages, resulting in cytokine release syndrome and severe systemic inflammation with end organ dysfunction.